I'm excited to introduce Dr. Douglas Smith from the Minnesota Epilepsy Group, who is going to move on to tell us about management of status epilepticus.
All right. Good morning, everyone. Thanks for coming out. Thanks for the invitation. And thanks to Dr. Worrell and all of the colleagues of the DSF that have done an amazing job assembling all this. I'm really excited to be able to participate, and it was local for me, so I really got to appreciate making this easy on me. My topic is going to be a little bit less evidence-based than Dr. Worrell. There's a lot better data that she was able to present. And when I say evidence-based, I mean we have good, clear, scientific answers to some of the questions that she was asking and the answers that she was providing. And this is especially specific to Dravet syndrome. So a lot of what I'm going to be presenting is going to be fewer figures, fewer science, and kind of more consensus, simply because we just don't have the good data for this compared to what she was just talking about. So starting with our objectives, I think you can read them, but I think it's helpful to understand. You hear this term status epilepticus thrown around a lot. I'm going to spend some time talking about a practical definition, why we approach it the way that we do, recognize the most common medications, both in the outpatient and the inpatient basis, and then I'm going to kind of spend a little bit more on the expert consensus, kind of what the general consensus is, and share mine as well. It's important that we always start by recognizing our financial disclosures. I do serve on the Speakers Bureau for UCB, and they manufacture Nasolam, and I'll be speaking about off-label use of this medication along with all of the other rescue medications. When I say off-label, I mean that this is not what it's specifically approved for by the FDA, which is very common in our world. As Dr. Worrell had mentioned, we usually don't have the Class 1 studies to prove that these are useful specifically in our age population or specific disease states. And I don't speak specifically about Nasolam, but it's important that we share that disclosure. So I want to start again by making a very practical definition of status epilepticus, because a lot of people have very different definitions, and even a lot of doctors have very different definitions. And when you look at old studies of it, you'll see often different numbers even thrown around for it. Some people will say 15 minutes, some people will say 30 minutes. And what I'm about to show you is that we're really kind of all technically right. What do we really mean by status epilepticus? And I think practically what I think of it is, well, ordinarily a seizure for the vast majority of individuals with epilepsy, without intervention, those seizures will stop on their own. It's a medical emergency, though, if they don't stop on their own, and if you need to actively intervene to stop it. And I think you as caregivers in the audience can tremendously recognize the difference of that. They are very, very different situations in terms of the amount of oversight you need to provide for your loved one. And so practically, really what we want to know is, when do we need to intervene? When do we need to step in and stop this? And so that is how, with the current evidence base, with our current practical definition of status epilepticus, we have a special term for that, which is really not the most useful or not the most eye-catching. We call it T1, time point 1, and I'll show you the actual paper with an even longer name than that. But it's really just practically, when do I need to step in to stop this seizure? When do I need to give this rescue medication? And what you're going to discover when I talk about this a little bit later is that there isn't a clear time point for every single person with epilepsy. Every single seizure is a little bit different. It needs to be treated a little bit differently in terms of what point do we need to intervene. And again, I imagine most of the caregivers in this audience recognize there are certain subtle features that they know if they don't step in on it, that seizure is not going to stop, and they need to be more aggressive with this. Then time point number 2 is really when we're worried about lasting harm. When does actual brain injury occur? And ideally, this should be long after time point 1. And so as you can probably guess with our catchy time T1 name, this is just called T2. And so our goal is to identify T1, treat it at T1 to avoid T2, to avoid getting to the point where we see neuronal injury, neuronal death, and potentially some of the complications that some individuals have talked about having seen on their MRIs. Now, a lot of this is theoretical, because I really don't know with any individual seizure whether or not this is going to stop on its own. And so a lot of the data that doctors pull from in order to kind of say this is the time point that we need to intervene is largely based in rats. And so When we talk about this, when we did the original paper, again, T1 and T2, as you can see in front of you, the left column is T1, the right column is T2. A lot of this data is pulled from rats, and some of the, particularly as it pertains to T2. We break it down. Again, for a generalized convulsive seizure, that tonic-clonic SE, what people often call a grand mal type seizure, we recognize that after 5 minutes of continuous generalized tonic-clonic seizure activity, it is unlikely to stop on its own. It still might, but it is now less likely than 50-50 to stop on its own. And so that is usually the benchmark that most doctors start at to say, this is when you're going to intervene on this seizure and stop that seizure. Now, we believe, again, based on rats, that we start to see neuronal injury at about 30 minutes, although there are some data to say that's not everyone's created equal that way. There are some people where we see immediately after a seizure where we get those MRIs where we can see some signs of swelling in the more sensitive parts of the brain. But generally speaking, 30 minutes is kind of our benchmark for grand mal status epilepticus or generalized convulsive status epilepticus. Kind of the next step down in terms of a seizure type is going to be focal status epilepticus with impaired awareness or impaired consciousness. We, again, have a little bit of a broader definition, a little bit more leeway before we really need to act, before we believe we need to intervene on these. We believe it's around 10 minutes and around 60 minutes where we start to see perhaps neuronal injury, or we see perhaps what we call entrainment, when your neurons start learning, hey, this is a pattern I need to learn and I need to strengthen this, which actually then sets you up for future seizures. For other types of seizures, for example, absence status epilepticus, it's a not really well understood entity, actually. It's one that we don't see nearly as often, and so we don't really actually have a clear time point where we know that this is likely to persist. And so we kind of have this very soft 10 to 15 minutes approximately, don't really know, and we don't really think that it causes lasting injury. Now you'll notice this is not the most exhaustive of lists. This is 3 seizure types, and I imagine many of the caregivers have people they care for that have more than these. And so you'll notice that there's a significant limitation in our scientific understanding about how do we define status epilepticus. Additionally, the data I just presented in front of you is not for individuals with Dravet syndrome. We know that people with Dravet syndrome are more likely to have longer seizures, and so their T1 is very likely going to be less than those 5 minutes. And so for the most part, most providers who treat Dravet syndrome tend to be a little bit more aggressive based on the idea that their T1 is likely going to be a little bit less. Additionally, this doesn't really apply to individuals. As I just highlighted, most of you, again, who have been around their child's epilepsy for years and years can recognize very, very subtle features to their seizures, which really doesn't get captured by this. And so it really requires a lot of individualized care, a lot of conversations with your caregiver to say, at what point do we need to start treating this seizure? And so, as I just mentioned, the limitations that we're really going off of is that these guidelines, the data that we're going off of, are really more broad. They're more generic. They're not specific to Dravet syndrome. And so a lot of times when people are coming in with their, we're giving our rescue medication at 3 or 5 minutes, that works for most people, but probably doesn't apply to individuals with Dravet syndrome. It doesn't apply to all seizure types, and we don't have data for all the seizure types to say at what point do we need to intervene on this. One of the classic ones that I always get tasked with, especially with Dravet syndrome, is myoclonic seizures. At what point, if you're continuously having myoclonic seizures, are these dangerous? And truthfully, we don't really have a great answer for that one. And doesn't apply to seizure clusters. That could be its topic entirely on its own. When I talked about the possibility of entrainment and neuronal injury, they really have that data for one long individual seizure. Well, what happens if the brain hasn't fully recovered from that seizure and now has another one hit and then has another one? At what point is that dangerous? And truthfully, again, we do not know the answer. And so this is still kind of something that's going to be very highly individualized, as I had mentioned, not evidence-based. It's going to be a conversation between you and your provider. And so what are our tools? What can we use, as I had mentioned, what can we work with our care provider to break these clusters? And really it breaks down to either it's a benzodiazepine or it's everything else. Now, benzodiazepines are the go-to, which the majority of people in this room probably the only things that they wind up using for status epilepticus and for their outpatient management of seizures. And benzodiazepines are a class of medications that all basically do essentially the same thing. They all tickle the GABA receptor. And the GABA receptor is an inhibitory channel in your neurons that essentially hit the brakes. They allow chloride in, which makes your neurons less likely to fire. And so they all act on that same receptor, and it's the same receptor that alcohol acts on. And so the side effects that we see with this are comparable to alcohol. And just like, again, I'm going to be a little bit colloquial here, so I hope you'll forgive me for being a little casual, but just like some people have different experience with wine drunk versus whiskey drunk versus beer drunk, they kind of, even though they're doing the same thing, they have a slightly different response. And so it's kind of the same thing when you're comparing the 3 different medications, again, all hitting the same receptor. Often people respond to them slightly differently. And the 3 ones that we use, for the most part, this is not exhaustive, is diazepam, lorazepam, and midazolam. And all of these medications, again, ultimately act on the same receptor. They're going to differ in how they interact with that receptor, and they're going to differ in terms of how quickly they get into the system and how quickly they get out. Now, you'll notice that each one of those medications then has multiple names afterwards. It's because each one of these medications also has multiple routes of administration. And so you can give diazepam in multiple different ways. You can give it as a pill or IV, which is Valium. You can give it rectally, which is Diastat. You can give it buccally or in the cheek, which is Intensol, or you can give it in the nose, which is Valtoco. Similarly, lorazepam, you can give IV or as a pill as Ativan, or you can give it in the cheek, again, as lorazepam Intensol. And then midazolam, which you can give as IV as Versed, or you can give it intranasally as Nasolam. And so you'll notice that we have what seems like a lot of options that kind of boils down to really kind of the same thing, because it's still by far the most likely to be effective in the treatment of status epilepticus. And this is true on the outpatient basis, but it's also true inpatient. So a child who has a seizure in the emergency room or on the floor, we're starting the exact same way. And so this is still our best go-to treatment options for breaking status epilepticus. In terms of everything else, we don't tend to use these all that much. Fosphenytoin, Dr. Worrell had mentioned really briefly that the role that it serves in status epilepticus is still an ongoing topic of conversation. We at least have a consensus at this point in saying it's not contraindicated, which I'll talk about a little bit further and a little bit later on. But it can be used on the outpatient basis intramuscularly, and I have a small number of patients that it was discovered that's what worked for them and that's what is used. And then lastly, there's the vagus nerve stimulator. We'll talk about that a little bit more in the future neurostimulation talk. But as Dr. Worrell had mentioned, the magnet. The magnet is an acute way that you can break a seizure without having to use any of the benzodiazepines. And so it's another one that you can use that acts differently compared to everything else. And so as I just mentioned, primarily you have a small amount of variation in terms of what medication you use, but you have much more flexibility in terms of the route of administration. So I'm going to break it down by the route. And so Diastat is really the only one that we use rectally and is still kind of the most commonly used because it's been approved the longest in the United States. And so it also is probably the most studied overall in terms of breaking status epilepticus on the outpatient basis. The biggest issue, as I think is common sense, is that it's challenging to administer. As even if it is the most effective, it's really hard to bring your child out into public and say, this is my rescue plan, to say that I'm going to administer a medication rectally, because there's obvious discomfort and problems in being able to do that. Additionally, it creates a sense of discomfort, which can slow down the use of it. And I'm going to highlight in a bit, one of the most important things is getting it in a timely fashion. And if you are uncomfortable with administering this for appropriate social reasons, or you want to make sure there's a little bit of privacy first, that's going to delay administering a potentially important therapy. And so as helpful as it is from a medical perspective in terms of getting it in, even if it gets a really good rapid absorption, that we have a fixed dose, we know exactly how much we're giving, you don't have to worry about dialing up to the correct amount and accidentally overdosing. That delay can create, in and of itself, a problem. And so we have been moving more and more in the direction of viewing more intranasal administration because it's much, much easier to administer. Now, as I had mentioned, this is off-label now conversation. Diastat is approved at 1 year of age. Valtoco is approved up to 6 years of age, starting as young as 6 years of age, and Nasolam is approved at 12 years of age. Now, we use these medications below that age because we know that they're effective, but that is currently the FDA label for them. And only recently have they become broadly available. Only recently have they become FDA approved and broadly available. And so we have started transitioning patients pretty consistently over to these agents, which have variable levels of success. So sometimes only the rectal administration works, sometimes the nasal administration works, and as I had mentioned, I think the biggest thing is to give it a try, because if you can give it more promptly, if you can now have that liberation where it's easier to administer, even if you do it in public, well, if it works more slowly, that still is quite liberating. Again, it's also rapidly absorbed, and there is fixed dosing for it. Again, what I mean by that is you don't have to draw anything up. You don't have to worry about, in your panic, did you give too much or too little. You know exactly how much you gave when you give one of these pre-dialed nasal administrations. Buccal used to be one of the more common forms of administration before Valtoco and Nasolam started getting on the market. It does have the slowest absorption of all of them. It is the easiest to administer overall in terms of our conversations with patients, primarily because I do hear often about a little bit of nasal discomfort afterward when they're getting it, or if they have partially preserved consciousness. We often hear about burning with nasal administration. I have heard that the Intensol doesn't taste the best, but compared to everything, I often hear that it's the easiest. It's nice in that there is adjustable dosing, and so I can kind of, if one's a little bit too little or a little bit too much, I can inch up on the dose without having to go back and change the dial on it. And additionally, a single vial of it is going to have a lot more administrations, and it also is cheaper. And so there are multiple reasons why I might still use buccal, where if it works, it's a very helpful and a very flexible therapy. Intramuscular, as I had mentioned, really only used for phosphenitoin, and it's not generally used. And so I'd love to sit in front of you and give you very clear data about this is what works best. And there are a lot of head-to-head studies that have compared these on an outpatient basis, but none of them have been done in Dravet syndrome. And so I don't think it's worth kind of breaking it down for you guys. So there really isn't a single clear winner. There have been some meta-analyses which have looked across all of these studies that have found intranasal midazolam to be the most effective. I think a lot of these are also kind of hindered by the issues I just mentioned of potentially that delay factor. If you're giving a rectal administration, it's probably going to take you a little bit longer to get them all set up, even if in a social situation. It's going to take a little bit longer just to kind of get them even set up, propped up, in order to give that rectal administration. And so even if you're giving it equally, or giving them kind of randomized between which one, there's going to be a little bit of a delay in the rectal administration potentially. And so what I consider the most important piece to it, more important than which medication you're selecting, and this is reflected in the consensus statements that Dr. Worrell had shared and I'm about to share again, is that you just need a plan. You need to have a medication, you need to be prepared to use it, and you need to have this all written out in advance and thought about in advance. And so make sure that you have your medication, make sure you have it on you as appropriate, and make sure that you feel equipped to use it. And so if it's not working, the first one that you're using isn't working, well then just keep trying. We typically will start off with Diastat at your standard dosing, and if it doesn't work, well usually we're going to start by giving it earlier. And so we have a few things that we can manipulate, a few variables that we can manipulate in order to try and get the things to work. And the first thing that I usually wind up doing for Dravet syndrome is say, don't wait the 3 minutes. Give it right away. Give it right at onset. We know that the sooner we give these medications, the more likely they are to work. And so we start with just saying, okay, don't wait. Again, we have, I think, a good scientific justification for that. The T1 for Dravet is probably shorter. And so don't wait 3, don't wait 5, give it right away. You can then adjust the dose of it. Again, we start off with the standard dosing, and if that is tolerated, we can then go up on the dosing. We can also then give the second dose a little bit sooner, and we kind of gradually ramp up on that dose as long as it's safely tolerated, trying to stop status epilepticus in conjunction with changing your everyday prophylactic seizure medications. And then if you're not seeing success with diazepam, well then do you try then going over to midazolam, again as Nasolam. Do you try going from rectal to nasal? Do you go from nasal to buccal? Just trying all the different formulations until you figure out what works. And this is quite intimidating in the early phases of Dravet syndrome, but usually you have a good, well mapped out system after a few years. And then I'll talk only briefly about what we do in the hospital. Bottom line is that there's, again, multiple treatment options. For some patients, I do have to work with them to develop a specialized treatment plan with their hospitals, and hospitals are getting better at this. A lot of my patients, as soon as you pull up their chart, they say they have this urgent care plan. And so they are getting better and better at being able to provide customized care to our children. And so failing that, though, still having that customized care plan slows things down. And so I try not to do that unless I absolutely have to, because emergency rooms typically have a protocol in place for status epilepticus. And the idea behind that is that they want to have medications immediately available to their providers that they can get into the child or the adult who's seizing. And so those are more readily available to those physicians. And so I try at first to say, don't develop a specialized plan. Until we know one medication works clearly better than the other one, I care more about speed than I care about which medication is being selected. And the main reason for that is we don't have clear comparative efficacy data. We don't have the direct head-to-head to say this one is clearly better. There are some that are probably better. But for most of my patients, we'll start off with the local institution's policies in terms of managing status epilepticus. In the hospital, as I had mentioned, we start off with the same medications, and just big difference is we more often do them IV because we have IV access in the hospital. In terms of the first-line therapies, it's Keppra or levetiracetam or valproic acid, which is Depakote, are the best two that we typically will go to first. Phosphenicoin, again, historically you will have a lot of people who will say they have an allergy to this based off of, again, the observation that prophylactic sodium channel blockers worsen seizures in this condition. I've had some children where before they knew that this was Dravet syndrome, where phosphenicoin was what worked for them. And so I've continued to use it to success with them, again, in emergency rooms. And this experience has been echoed by other care providers with Dravet syndrome. And so it's not contraindicated, although it's not necessarily I will say if I get the phone call now with a known Dravet syndrome patient, the benzos have failed, I don't usually go first to phosphenicoin. I tend to go to Depakote first, personally. Phenobarbital, it used to say we cannot use it because there were reports of it worsening seizures in status epilepticus. The current consensus is that you can use it, just not first line. And so it's not a commonly used medication, but for some it helps. As I had mentioned, we have consensus statements now. We have a couple of them that have looked at this exact topic. And so when we don't have good scientific data, they essentially ask a whole bunch of people who are treating Dravet syndrome regularly, usually at conventions just like this, and they say, what does everyone think about this? And if there's a greater than, I actually don't know the cutoff off the top of my head, a certain percentage of people who agree with it will say that there's strong consensus. And so I'm going to highlight what I just mentioned. The most important thing is that all patients need a home rescue medication and hospital and seizure protocol, which can be carried out. Again, you need a plan. It almost doesn't matter what the plan is. There just needs to be one, and you need to be prepared to use it. At this time, this was published in 2017 before Valtoco and Nasolam were FDA approved. The guidance was that for children under the age of 6, the recommendation was rectal diazepam or buccal or nasal midazolam. And as they got older, age 7 to 12, is when we transition typically to get away from rectal administration. I personally, my cutoff is usually around school age, it's around kindergarten. So 5 or 6 is where I typically make that transition. Schools are getting increasingly uncomfortable with rectal administration now that nasal administration is so widely available. And so I've just started making the transition as soon as kids start going to school. Again, so I think I want to highlight the lack of consensus on this. So just to show you the ambiguity, at a minimum, rescue medication should be given within 3 to 5 minutes of onset of a convulsive seizure in all age groups. Now you recognize that says that includes at onset versus at 5 minutes, which are very, very different recommendations. And so they couldn't get the experts to agree on at what point. And I mean, I certainly follow that same practice in my own patients with Dravet syndrome. Most of them give it at onset, but some of them do wait a little bit longer, and it's mostly dependent on the seizure type and based on the history of what their previous seizures have looked like. As I mentioned, in those with a recent history of convulsive seizures that are typically prolonged, rescue medication should be given at the time of convulsive seizure onset. So that was kind of their way of sneaking in that you probably should give it early, especially if in the past we've had prolonged seizures, which again is the norm for Dravet syndrome. Second dose within 5 to 10 minutes, as I just mentioned. That's often what we'll add in if the first one isn't working. For brief convulsive seizures that are clustering, rescue medication should be administered. Notice there's no definition what the cluster is. And that's something that we all struggle with, I think, both as care providers and probably you as caring for patients, is that we don't have a single definition of what constitutes a cluster. And you can see that last one, for clusters of non-convulsive seizures, no consensus. We couldn't agree at what it actually looked like, when should you administer rescue. The more recent consensus, sorry, the citation didn't come up there, from 2022, adds that, again, all children with Dravet syndrome should have a home rescue medication, and that if they present with a prolonged convulsive seizure that has not responded to 2 appropriate doses, they're saying the first-line non-benzo treatment should be Keppra, which is levetiracetam, valproic acid, which is Depakote, or phosphenicoin, which again is elevating. We're getting more and more moving up on the algorithm in supporting phosphenicoin. We do not recommend as first line doing a Versed infusion, which is essentially trying to putting a child into a coma in order to stop the seizure. We don't recommend that just after 2 doses of benzodiazepines. And we don't recommend phenobarbital or lacosamide, which is Vimpat. Vimpat is another sodium channel blocker, and so in a lot of adult hospitals in particular might use that as their next line agent, and that's where you might kind of come in and need to amend those protocols. Midazolam or phenobarbital, as I had mentioned, we don't want to do that as first line. We would want to do that Keppra, Depakote, or phosphenicoin first, but they are appropriate once those medications have been given and failed. In terms of my personal, again, I've tried to give the data as best I can, but it's limited. So my personal approach is I take it on a case-by-case basis. And it's kind of, as Dr. Worrell had answered a lot of questions, it's a conversation between you and your provider. It's exactly the same situation here. And then you have to sit down, you have to talk and say, what is it about this seizure? What is it about this scenario that is more likely, or historically what has happened with these seizures? Which ones are more likely to result in a seizure that won't stop on its own? When do we need to intervene? Because generally speaking, a seizure that stops on its own recovers faster if you don't give that rescue medication. And so we try to avoid it, but again, we have to take some history into account in terms of figuring out when do we intervene and which seizures do we intervene on. As I had mentioned, I don't wait on Dravet. When I first get the SCN1A mutation, even if I'm not sure it's a diagnosis of Dravet, I tend to be more aggressive with my rescue medication. And I say, we're not going to take the chance, particularly in these young kids. We're going to give it right away at onset, is my rule of thumb. And that, again, that is not universally agreed upon, but that is my personal approach because I really would do everything I can to avoid those prolonged seizures if possible. And if it's not working, just keep trying. There are a lot of options out there. Those options are always growing. And so if it's not working, mess with the dose, mess with the timing, mess with the route of administration, adjust whatever variables we can adjust in order to try and get better seizure control. Because recurrent status epilepticus, I mean, again, for everyone in the room, I don't have to talk about the medical consequences of it. The life consequences of it are devastating. And as Dr. Worrell had mentioned, we do think that that is contributing to the overall cognitive outcomes, all the non-seizure outcomes. And the better we control this, the better everything else is likely to turn out. My personal experience is that I think intranasal midazolam is the most effective for Dravet syndrome. I've had significant personal success in treating these seizures with Nasolam, and several of them where they did not respond to intranasal Valtoco. And so I have been going to Nasolam or intranasal midazolam more and more often, just because I've personally found it more effective. And there is some data to say that rectal diazepam is more effective than intranasal, and that is likely related to the more rapid absorption and higher intracerebral concentration as a result of that. But there is some data to support, not for Dravet syndrome specifically, that again, intranasal midazolam might be marginally more effective as well. But that data isn't strong enough for me to present that. I'm just my personal opinion. So I think I'm perfect on time here, so we'll pause for any questions.
Hi, can you hear me? I don't know when it will be appropriate to ask this question because it's a little off, but it's still, I think, very important to what we're discussing. So our son has always had status epilepticus, and the emergency room, whether they like it or not, has known us very well. So one major problem we have had as a family, and we have not gotten it rectified yet, is that when we enter the emergency room, we always carry a written emergency care plan. We always travel with emergency, and we are very assertive with ourselves coming in, but they are yet to find the emergency care plan on their system. And we are talking about a high-level children's hospital. They've switched over twice. I mean, I've even gone to the point of trying to be on the family advisory board to get this fixed. It's only fixed based on, you know, us, like, well, we're going to put it here, we're going to put it here. But when you're going in and you've already gave, you know, rectal, intranasal, diastat, or one, you know, two you get an intranasal, and then 2 rectal, and then you're heading to the, you know, he's still seizing. I mean, you can't talk them through anything until they find, and so you're sitting there waiting on minutes and minutes and minutes before he's treated. So you have any support on that? And I would love to hear of any other parents that have struggled with this, and if there's any kind of people that are here that represent the programs within the hospital that they use.
Yeah, I wish I could give blanket feedback on that. It's a fantastic question, and actually conversations with other caregivers might be kind of your best bet and say, this is what worked for me. For me personally, it's often, I mean, I start off with the written care plan. If that is not enough, then it follows up with a phone call to that emergency room. And then often you don't get connected to the right person. Often I struggle at getting to the right person within an emergency room if it's not my own hospital that I work within, and I don't know which person I need to contact. And so a lot of times they don't know who to shunt you to. And so, you know, for me, it's just, you know, kind of, you know, the squeaky wheel makes, you know, squeaky wheel gets the grease. And so, you know, I make those phone calls, and I don't have any more intelligent feedback than that, because, I mean, often it's the same phone numbers that I'm calling a lot of times that you guys are. But if other parents have other ideas or better experiences, I mean, I would love that feedback. Yeah, I'll be around all day, so I'll be happy to answer any questions. Thank you. And thank you for coming.